us on evidence-based practice. This time, the theme is on neuro-ophthalmology, and the question we are addressing is surveillance in ethambutol-induced optic neuropathy. What is Optimum? There is really no dearth for consensus guidelines on this. We even have Dr. Rohit Saxena group has come forth with very lucid guidelines in our country itself. But the challenge is of the variations of putting these consensus guidelines to practice across populations who are very different in their socio-economic, in their ethnic, in their body structure, in their medical, every kind of profile. So this particular session will be focusing on how we are supposed to be dealing with these variations. Are the variations, how much of deviation from the rigid protocol is acceptable? Because tuberculosis is a rampant reality in India, and we as consultants, whether we are in rural practices or in the urban or in the referral centers, we are all faced with patients who are taking ethambutol. So how best can we tailor this surveillance guidelines to the best benefits of our patient without undue risks, but in a perfect balance of economics also? So this is what we are focusing on in this coming hour, and that is why the evidence we are reprising this time is not about the consensus guidelines, but about the variations in real life patterns itself. That is the exact article that has been chosen, and it is a review article that is dealing with more than 1 lakh people, and it is from the Clinical Pharmaceutical Journal, which is of June 2025, very recent. And as usual, our exquisite research mentor, Dr. Praveen, will be hand-holding us through the intricacies and through the nuances of how best to interpret the article. And this time, I have put some thought into the clinical experts who are here with us, because again, I thought we should be focusing on the variations in practice. And we have first, let us welcome Dr. Sudha. She is a very senior and experienced ophthalmologist, heading one of the most busy medical colleges in the state, GMC Thrissur. And she has been quite recently, she was in Idiki, also one of the remotest medical colleges in our state. So apart from her thorough knowledge of the subject and experience in dealing with the disease per se, I'm sure that she's one person who must have had a lot of challenges in implementation of these screening protocols to the largely underprivileged section of society, the grassroots level implementation of these things in her practice. So whereas the other clinical expert with us is an equally accomplished Dr. Nina. She is very familiar to us as a leading name on all the academic and scientific fora related to strabismus and pediatric ophthalmology and neuro-ophthalmology. And she has the Department of Strabismology, Pediatric Ophthalmology and Neuro-Ophthalmology at Giridhara Institute, a leading premier institute in the private sector. So her profile of patients and her experiences in dealing with this disease and the implementation of this very same guidelines may be vastly different. So it will be very interesting to bring out conversations which may bring to the forefront exactly the issues we are looking at how differently we can actually come to targeted medical practice using the same guidelines. So that's what we will be looking at in the coming 1 hour. And apart from being people of such expertise and experience, both of these, both Nina and Dr. Sudha, are having a remarkably brilliant academic and research credentials as well. Dr. Sudha, as we all remember her, is a remarkable editor of KGO, and she has done such great work during her tenure. Dr. Nina is the assistant editor right now. She's with me on the KGO team, and a tremendous help to me to run things the way KGO is running now. So I think being a platform that blends experience with evidence, we are really fortunate to have both these experts with us today, and a warm welcome to Dr. Sudha and Dr. Nina. It's my pleasure to have you on this platform. Welcome. And and I think, before we go on to the scientific session, we always begin on a high note. Let me announce the winners of the KGO quiz of the last episode on recurrent corneal erosions. So the winner this time in the first position comes none other than Dr. Thomas Arun Varghese. He is a consultant in glaucoma and neuro-ophthalmology. As you can see, he's a very busy man, having consultancies in 3 different hospitals. And also Dr. Akhil, assistant professor, PK Das Medical College, Palakkad. Despite my best efforts, I am very sorry I couldn't catch his full name because there was no response through mail or through the phone. But however, congratulations to both the winners and keep quizzing with KGO. And now it's time to go straight into the session. I hand over this forum to Dr. Praveen Nirmalan for his appraisal of the article.
Oh. So, okay, we are talking about Ethambutol optic neuropathy surveillance, variations in real-world screening practices, and associated factors in a nationwide cohort study, published in Clinical Therapeutics, 2025. The 2 questions of interest when we are looking at this particular article. One, the surveillance of Ethambutol optic neuropathy. So the practice patterns, or the screening practices, the uptake of or the utilization of surveillance, the mode of surveillance, what's used, and are there any particular trends or patterns that we need to be concerned about? It is the 5th of the 5th session. And so I'd like to reiterate what we need to consider when we are reading a paper. One, you might want to read a paper to find an answer to a clinical question. You're having a doubt and you're trying to find an answer to it, and you search the literature for that particular piece of the puzzle. You might want to validate your personal observations on care by checking out if your personal observations match or do not match with the evidence that's out there. You might want to explore further directions on what's happening, what's new, what can be looked at further, what are the gaps that you want to address. So in each of this, you need to be looking at a paper with a critical mindset. Now, a critical mindset does not necessarily mean that you're looking at the paper trying to find out all mistakes that are possible. A critical mindset is that you're looking at a paper trying to interpret the paper in the context of limitations, keeping in mind that every study will have limitations. It's not going to be a perfect study. Every study will have limitations. So we need to be aware of the limitations, but we don't need to judge the paper only by its limitations. We need to be able to interpret the results that are presented there in the context of the limitations and see if it makes sense for us to translate that into our clinical practice. The current study wanted to investigate real-world screening practices for ethambutol optic neuropathy and how these practices vary across demographic and clinical factors in a nationwide cohort in South Korea. As you look at this, the first question that you might want to keep in mind is, what's the situation in our country, or in, if you want to be more specific, in Kerala? Even though the population and practice patterns and uptake patterns in South Korea might differ from that of Kerala, is there something that I can pick up from this particular paper within the context of my practice in Kerala? So that's the way you would start looking at this particular paper. Based on the question, you would not necessarily want to be too much caught up with a statistical framework in this. You would want to look more at the patterns that are there, the gaps that are there, try to relate that with what you are seeing in your practice here, try to see if there are similarities, try to see if there are dissimilarities, try to see if you are even looking at the problem in the first place. So they had a cohort of more than 1 lakh, nearly 1,20,000 patients, individuals in South Korea, who initiated ethambutol therapy between January 1, 2015 and December 31, 2021. And the data source was the National Health Insurance Review and Assessment database. They compared the screening practices of ethambutol users, focusing on demographic and clinical characteristics between those who underwent baseline examinations. They defined the baseline examination as the first ophthalmic examination after starting ethambutol, and those who did not have a baseline examination. And further on, comparing individuals who received subsequent monitoring and those who did not. You look at the main results. Now, there are a few things that you need to keep in mind. One, that the data source is a retrospective one to a certain extent. It is coming from a health insurance database. It may not have a uniform standardized definition that's applied across all settings. It may not have data that's being collected uniformly or reported uniformly across all settings. It would have limitations of what data is being collected. And that's why they call it a real world study. So what's happening in the real world is more of a pragmatic exercise rather than a strict lab controlled exercise, which may not translate into the real world. So this is, in a sense, a good way to look at this data. They found that the mean age of patients was 55.7 with a standard deviation of 20.7 years, and that was nearly 1 in 5 patients, 17% of the patients were in the 50 to 59 years age group. So mostly towards the young elderly side. There are more males, 56.2%, mostly rural, 52.4%. Optic neuropathy was found in 2.1%, vision impairment in 0.4%, and blindness in 0.1%. Now, each of this has to be kept in mind as you continue reading the paper and look at the practice patterns, training uptake patterns, and things like that. One, that you're seeing that most of the data is from males, or most of the reporting is on males, so most of the uptake is by males. Rural population, slightly more, 52.4%. A low prevalence of, or low magnitude of optic neuropathy in the database. Vision impairment is low, blindness is low. The primary indication for ethambutol prescription was pulmonary tuberculosis, more than 76.1, nearly 76.1%. And most prescriptions were from referral centers, 73.4%. The mean daily dose was 902.3 milligrams, and the mean cumulative dose of ethambutol over the course of treatment was 317.8 milligrams. Mean duration of ethambutol use was 12.1 plus or minus 11.6 months, so about a year. The fact that most prescriptions are from referral centers might be related to the healthcare infrastructure as well as the way it's structured and the way it's getting into the database, the insurance database. So coming to the ophthalmology assessments, what we use if you are looking at a surveillance, ophthalmic surveillance system. They found that fundoscopy was used in 95.8% of assessments. Fundoscopy is relatively common, easy to do, about the first line of assessment. OCT was used in 48.7, so less than half. Automated visual fields, less than half, 34.1%. Color vision, 1 in 10, 10.3%. VEPs and ERGs, very much less. So most of the assessments are based on fundoscopy. A key point to note is that the proportion who completed ophthalmic assessments within 6 months of starting ethambutol is 13.2%. So that's low. That's something that you need to consider and something you need to think about what's happening in our scenario. Among people who are started on ethambutol, what proportion might have an ophthalmic assessment within 6 months of starting therapy? Will it be as low as 13.2%? If it's as low as 13.2%, is it because an ophthalmic screening or an ophthalmic assessment is not absolutely necessary once you start ethambutol for a baseline assessment? So you need to reflect on those things as you see that percentage. The proportion of baseline assessees who completed subsequent assessments within 6 months of baseline assessment is also low. It's 11.1%. So if you had a low proportion had a baseline assessment within 6 months. Among those, only 11.1% had a subsequent assessment. So you're seeing a huge gap there, even if you had the baseline assessment. So it gives us scope to look at few questions there. Why is it low? Is it the way the surveillance system is set up? Is it the way the screening practice is set up? Is it that it is not necessary to screen everyone, or what is it? So think over those parts. Then, if you had the baseline assessment, why is a subsequent uptake low? What's the gaps there? What's the barriers there? Is it that it's not necessary? Is it that if you are considered to be low risk on the baseline assessment over a period of time, then that you need not have any subsequent assessment? And the baseline assessment is within 6 months of starting ethambutol therapy. We also need to note that the authors have mentioned that the main cohort included 20.6% of patients using ethambutol for less than 3 months. So when we say 13.2% had assessment within 6 months, we're not sure if that includes this 20.6. It can become more if part of this 20.6 decide to take up baseline ophthalmic assessment. And 12.9% for 3 to 6 months. So it's a group that can still take up the baseline assessment. The question is, without moving further in the paper, the question that comes to mind is it because they're not referred for an ophthalmic assessment? Is it because an ophthalmic assessment is not considered necessary? Which then brings us to what is the criteria for having an ophthalmic assessment and in what period should it be done as a baseline assessment after you start ethambutol. Then you try to link it back to the magnitude of optic neuropathy. You try to link it back to blindness and the visual impairment, 0.1%, 2%, 0.4%. And then you start to try to relate that and then try to figure out, well, what should be done, what can be done. The authors report that in the baseline assessments, generally, the people who took that up are generally younger with a mean age of 54.4 years, compared to those who did not receive such examinations who had a mean age of 55.8 years and a P less than 0.001. Now, the key thing here, which we talked about in all the previous sessions, is that don't rely only on statistical significance. Clinically, do you think a difference of 54.4 years and 55.8 years is significant? Is that clinically significant? You can argue that, well, the P is less than 0.001. The counter argument can be that, well, if you have a large sample size, even small differences can become statistically significant. Right. So that's one of the things that it's one of the things that drive the estimation of an appropriate sample size. If you have a small sample size, even a significant difference may not appear to be or may not be found to be statistically significant. If you have a more than required, a large sample size, a more than required sample size, even a small difference can appear to be statistically significant. So don't just go by P less than 0.001. Look at the numbers there. Check to see if that's clinically significant. A 54-year-old and a let's say 54 and a half years and close to 56 years, is there a big clinically significant difference there. Baseline assessments were more common in people who had longer treatment durations. Possible because they are the ones who had enough time to come for a baseline assessment. Probably they are the ones who had enough contact with the primary prescribing doctor to be told to go and have a baseline examination, right? They had slightly higher daily doses than those who did not undergo baseline exams. Now, again, if you look at the daily dose, the mean dose is 911 and 901. So again, is that a big difference there? 13.7 months and 11.9 months. Just above a year and just about a year. So are the clinically significant differences? So not every single statistically significant difference needs to be translated as that it must definitely be clinically significant also. You need to bring that judgment in based on your practice, your experience, and then your interpretation of what it is. Is it clinically significant? Yes, it's statistically significant, granted. But when I translate that into clinical significance, when I translate that into my practice, does it retain clinical significance for me? Now, this is an interesting statement that possibly can lead to a little confusion later down the line in the article. Nearly equal male to female ratio, 49.1% male and 50.9% female, among those who underwent baseline examinations, compared to a higher proportion of males among those who did not undergo baseline. The key point here is that they're reporting the male to female ratio. As I go down further in the article, they then talk about the proportion of females that are taking up the baseline assessments. And there's a subtle difference that's coming there. So here you see that baseline assessment, it's nearly equal male to female ratio. When you go to table 4, I think it's table 4. Then go to table 4, you will find that in baseline assessments, females are less likely to have undertaken the baseline assessment. Then the confusion can come, well, how is that possible if they're... And the difference is that here they're reporting male to female ratio. There they're reporting the proportion of females that have undertaken the baseline assessment compared to the proportion of males that undertook the baseline assessments. So there's a slight subtle difference there, and it can be a little confusing if we do not discern that or differentiate that subtle difference. When we went to subsequent assessments, we found the report that the patients who underwent subsequent assessments were older, had longer treatment duration compared to those who did not. Well, if you had a short enough treatment duration, you may not have gone for a subsequent assessment. The subsequent assessment is done after 6 months. Once the baseline is done within 6 months, then you have the subsequent assessments. So if your treatment duration was 7 months, you may not have gone for a subsequent assessment. So you need to factor those things also as you look at the significance here. The daily dose did not differ significantly between groups. Again, they report that an almost equal distribution of males and females, or male to female ratio, among those who received subsequent monitoring, as opposed to a higher proportion of men among those who did not. So the point I want to make here is don't just go by the p-values. Try to relate that back with what's happening in the whole process of data collection, what's happening in the, how do you relate that statistical significance to clinical significance or clinically significant differences, and whether clinically you feel that the small differences really do make a difference. And also keep in mind that when you're having a large population size, steady population size, small differences can show statistical significance. It need not always necessarily mean that they are clinically significant differences. They found that people who are younger, less than 40 years, had fewer screenings compared to those who were aged 60 and above. Now you can try to relate that with the severity of the condition, the duration of treatment, whether it's early, whether it resolved early, a lot of other factors. And that's where then when you're looking at a result like that, you want to then look at a multivariate analysis to see if age is still a factor after you adjust for other factors, other confounders. Screening frequency increased with the duration of ethambutol use. Again, you need to relate that to the fact that, well, if you are using ethambutol for a longer time, you're more liable or you're more likely to be told to go for a screening. If you have resolved early, you may not be told to go for a subsequent screening or even for the primary screening. They didn't find any significant differences for daily dose or sets. Screening rates were similar between metropolitan and rural residents, but varied significantly by medical specialty and hospital type. Then we come to the multivariate analysis. And in the multivariate analysis, they say that age was found to be a significant factor with a slightly decreasing odds ratio for subsequent monitoring. But if you look at the odds ratio, it's 0.99, so close to 1. In the 95% confidence interval is 0.989 to 0.991. So close to 1. Based on this, we will say that that younger individuals were more likely to receive timely follow-up examinations. But it's so close to 1 that even though it's statistically significant, it's not very sure whether it will have any clinical significance in terms of age. When the 95% confidence interval spans 1 or when the OR is 1, it indicates that there's no difference between the groups. And this is so close to 1, just below it. So we need to think of two things here. One, that the uptake of screening or the population that took up screening is low, 13.2%, and then subsequent screening is 11.1%. So how reliable is this particular result? It's not such a big difference to say that, well, even if that's low, it's great. Is it related to the fact that the uptake is low? Is it related to the fact that there are a huge number of people, more than what's required? And so even the small difference is showing up as a significant difference. And you think over the differences in age 54.5 and 55.8, and then you try to connect that. So there's a bit of back and forth that you need to keep doing. Sex was another associated factor, with females being less likely to undergo a baseline and subsequent monitoring than males. And this is where the statement that they made earlier, that there is a nearly equal male to female ratio in those who took baseline screening, might come up as a statement that produces a little bit of confusion. So here they're saying it is lower. Both in the bivariate as well as in the multivariate analysis, it's lower. Well, earlier they reported the male to female ratio. So it would have been easier if they had reported this also there, so that confusion could be reduced a little bit. So there's a little bit of confusion coming in the way that it's presented, and unless you're really careful, you're going to miss that point. So when you look at the multivariate analysis, now one weakness that is there is that they have not mentioned what they're adjusting for in the multivariate analysis. And we have to make a presumption on that. When you see a table like this, you have the odds ratio, you have the 95% confidence intervals. The things that you need to look at is the odds ratio below or above 1. If it's below 1, a lower association. If it's above 1, a higher association, or more likely to be associated. If it's 1, there's no difference between the groups. But don't just stop there. You need to also look at the 95% confidence intervals. And you need to look at both numbers of the 95% confidence. One is a upper limit, one is a lower limit. So if you look at females, you will see that the lower limit is 0.702, upper limit is 0.752. Both are below 1. which then indicates that there is a statistically significant difference. The females are less likely, males are the reference, less likely than males to have a baseline examination. We go to the subsequent monitoring again, 0.720, 0.776. Females are less likely to have subsequent monitoring compared to males. Also consider that most of the data is from males. So as it is, females' uptake of services is low. Within that, you are getting a lower uptake of ophthalmic assessments also. So you need to look at it that way. Now I will show, so infectious disease compared to pulmonology, baseline assessment 0.919, 95% confidence interval, 1.078. So it tells us that there is no significant difference between prescribing patterns of infectious disease specialists and pulmonologists, even though the odds ratio is 0.996. So it's marginally lower. The 95% confidence interval tells you that there's no significant difference between infectious disease specialists and pulmonologists. Whereas other internal medicine specialties are more likely to prescribe ethambutol based on the 95% confidence. So always look at the 95% confidence interval. Don't just look at the odds ratio and reach an interpretation. Don't look at the p-value and reach an interpretation. Right? So that is just something that I want you to have as a take-home message. So the key points here is that, well, this particular paper is talking about screening practices and uptake of screening in a specific population. They have a huge database. They have limitations, and they have described those limitations. That's specific to their population. What's the practice here? What's the screening practice here? Especially since we have a good proportion of tuberculosis. What proportion of patients with tuberculosis are prescribed ethambutol? What proportion of patients prescribed ethambutol are referred to an ophthalmologist for an assessment? Where should that referral be to? Should it be to a general ophthalmologist? Should it be to a tertiary care center? And what do we know about the magnitude and associated factors for ethambutol toxicity and prescription patterns for our population? What proportion of users, ethambutol users, are screened for optic neuropathy? Is there a threshold for ethambutol dose and duration that increases the risk for optic neuropathy? What do we use to screen? Most of the screening is based on fundoscopy. Less than half have, what is that, OCT. Just about 1/3 have visual fields, right? So is fundoscopy enough? Does it pick up early signs? Does it pick up the late signs, the manifest signs? Are we missing subclinical or early stage neuropathies or signs of toxicity? So what do we do as part of an ophthalmic assessment? Do we need to screen all ethambutol users, which is important if you have a huge population of patients with tuberculosis and a huge population of patients who might be prescribed ethambutol, whether it's with isoniazid or not, or prescribed ethambutol. So do we need to screen all of them? Is that feasible? Or can we filter as high risk, no reasonable risk for ethambutol associated optic neuropathy? Can we filter prior to the baseline screening? Can we filter at the baseline screening as high risk and hence need subsequent monitoring at what intervals? Does not need subsequent monitoring based on these criteria. Can we provide targeted screening? Again, assessment methods. Should we look at functional and structural? Is it possible? The question comes, what is possible at the primary level or at the general ophthalmology clinic level, what's possible at a secondary level, what's possible at an advanced tertiary care level, a specialty clinic, right? An easy question would be, what do we do to assess, or do we even consider the eye in the tuberculosis care centers or clinics across the state? So do we have an ophthalmic screening protocol for ethambutol users? Now, there's a difference between having an ophthalmic screening protocol that is accessible and used by ophthalmologists and having a screening protocol that is shared and is made aware to the primary physicians who are doing the prescription of ethambutol. Right. So we are seeing that including pulmonologists, including internal medicine specialists, the referral or the uptake of ophthalmology assessments is low. 13.2% is low. So it's not just enough that we have that screening protocol in place and that ophthalmologists follow that screening protocol. It's also necessary that the people who prescribe ethambutol are made aware of this, are made aware of the need to probably send patients for an ophthalmic assessment, which then means that we need to be very clear that this is when you send, this is what you send for, this is when you might need to send for subsequent assessment. This is what the way we will assess, this is what we are reporting. And this is why we are calling for a subsequent assessment. Right. So I will take leave and hand it over to Latika to mildly harass the clinical experts. Thanks.
Thank you, Dr. Praveen, for the opportunity. So I'll take it forward from here. And thank you for all the questions also, because it makes it all the more easier for me. Let's start with that question of when should we do that first proper ophthalmic examination with the purpose of detecting an ethambutol-induced optic neuropathy where no suspicion exists in the mind of the patient. So we have situations where patients are referred to us by their physicians. We have situations where the patient has come to us for a change of class and we just find that this patient is on ethambutol. So there is that is something called an opportunistic screening, whether we have to practice that opportunistic screening as a policy, or whether we have to just confine ourselves to looking at patients in that sense only with their coming with the reference for ethambutol to look for ethambutol induced toxicity. That is one question. And the second one is, when should we do it? Because nowadays we are also having referrals coming to us before starting ethambutol. We are going to start ethambutol. Please do a baseline evaluation. That type of references are also coming from the pulmonologist. So these are two extremes of the spectrum that are coming to the ophthalmologist. So I think the first let me open this by asking Dr. Sudha, do you recommend opportunistic screening? Do you look at patients only if you get a reference letter for a proper ophthalmic screening? And is it that a baseline examination should be before this ethambutol is started at all?
Thank you, Ladika, for inviting me to this very interesting topic. And actually, you invited me as a medical college expert. Thank you for that warm welcome and that warm introduction. It's very happy to be back for KJO webinars.
Thank you.
So let me give you a background first before you decide actually what is happening at the medical college level. Now, I have worked at both Idiki, where Idiki Medical College is actually hardly a medical college, it's more of a district hospital. So basically, the screening is done by the district hospital people. And here in Thrissur, we are doing a complete medical examination. That is one. Second thing is, this national TB program is now actually NTEP, National TB Elimination Program. So there is a little bit of a change from the older regimen of having alternate, I think 3 times a week or something, they were giving directly observed treatment. Now it is actually daily treatment. But the problem is that in a center, which is a tertiary or a secondary center, they do not directly give the medicines. They diagnose it as TB, refer it to the NTP clinic or to the person in charge, the nodal officer, who gives the regimen, who calculates the regimen, and this regimen, if the patient is uncomplicated, he is sent back to the PHC to collect the medicines under direct observation through ASHA workers there, right? So one problem here is that the PHCs don't have ophthalmologists. Generally, so uncomplicated pulmonary TB patients will probably going back to their home and for only 6 months screening are unlikely to meet an ophthalmologist unless they are seen at the district level or at the tertiary level before they are leaving for this. So the problem is, are they referred to an ophthalmologist? No. In at least in the tertiary centers and the district levels, now we are more dealing with drug-resistant TB rather than plain and simple OPD TB patients. So what is happening is these directly patient OPD patients who are not getting admitted are just informed that they will need an ophthalmologic screening and should go back and get it screened. But I don't think any of them will be really following that up if there's an uncomplicated case. They may. I'm not saying they won't, but that is just, so they're starting ethambutol even before they are actually going for, they're not screening before starting ethambutol for uncomplicated cases. The second one is Idiki, when it was just a district hospital, there was a surveillance pattern there. They were actually going to these hilly areas, surveying people and bringing back people who were extremely drug-resistant population or extremely mainly drug-resistant, so XDR and MDR patients. In those patients, those are complicated cases. When they're bringing them, the first checkup was being done for ophthalmology. So they was before starting the multiple drug regimen, I think they were being sent to ophthalmology. But those are only the drug-resistant cases, not the simple pulmonology cases which are uncomplicated. Most probably those are being referred back to where they came from. Now, in a tertiary center, it's even a little more different. Tertiary center, all the clinical departments are seeing the patients, diagnosing them as tuberculosis and referring them to the NTP clinic. And here at the NTP clinic, they are diagnosing, they're sort of making it whether this patient requires IP or OP. So OP patients, of course, if they're uncomplicated, being sent back to their places. If they are complicated, they are being sent towards the TB center, the district TB center. So at the district level is probably where the initial screening of ophthalmology is going to take place. So those patients are not coming to the ophthalmologist in the medical college hospital as OP. But IP patients who are lying, most probably these IP patients will be people like orthopedics cases or severe pulmonary cases. Those are likely to be sent to us for screening. So what is happening is, it is basically the IP and the more serious patients who are getting an ophthalmic screening because they are in the hospital for a longer duration. The others, I'm not very sure if they're going back to an uncomplicated cases, if they're going back to a PHC, whether they're getting their facility. So that is one. So that is what is happening. Now, you asked me a question on baseline examination. So why do we need a baseline examination? The first thing that is, to me, most important is in a tertiary center like ours, it is not just tuberculosis. People are complicated cases which we are seeing. So they probably have comorbidities like glaucoma. They have comorbidities like diabetic retinopathy. In many cases, I have started seeing TB patients from around 2011-12 when there is a huge epidemic of HIV patients. So those people were getting TB treatment also. So I will give you an example. I saw an HIV patient. We treated him with ganciclovir. He was improving and going back. But after 1 year of treatment, I don't know what was the reason, he started developing bitemporal hemianopia. Now, at that time, probably we were not so aware of all this. I missed the fact that he may also have been on ATT because the CD4 count is low. So these people start ATT concomitant. So maybe one reason he stopped anyway. He had not, by the time we detected the field effect, probably I think ethambutol was over. The ATT treatment was over. But what was happening was there was severe bitemporal hemianopia which developed. Actually, we became quite poor vision, almost blind. So we had probably missed that because we were concentrating on the HIV part. So the reason why we do a baseline examination is to detect whether there is any other concomitant defect which could lead to this severe visual loss after we take ATT. We have to recognize that there could be something which is pre-existing. So diabetic retinopathy, if it is pre-existing, he may be having already a cause for decreased vision loss. So unnecessarily, we should not contribute or we should not say that this is due to ethambutol. So the baseline examination is important. And I think in that it is not just vision. Perhaps we should, if it's a complicated case, perhaps we should do a field assessment also. Like I said,
Okay.
we missed in cases of HIV. So
Okay.
maybe it's, yeah. Okay.
Okay. Thank you, Dr. Sudha. So, can I think, just to conclude the answers to these questions, the crux of the matter is that practically it is the complicated cases and the IP cases that are being 100% getting ethambutol optic neuropathy surveillance in the government setup for whatever reasons. But what is the ideal? The ideal is that there should be a baseline ophthalmic examination in all patients who are supposed to be put on ethambutol regimen, ethambutol regimen. But whether it should be done before they are put on the regimen or not, that is a question that needs to be addressed. So what do you say, Nina, about Dr. Nina, what do you say about that? Do you need a baseline full evaluation before starting ethambutol or just after starting it?
Yeah, I feel a baseline evaluation is ideal because, as ma'am said, you can also pick up people who are, you can, prioritize who require early screening. I mean, who require close follow-up and who require maybe a little late follow-up if they have associated high risk factors. For example, we know that the patients who are likely to develop ethambutol toxicity are patients who are having an older age group, who are underweight, then who are having coexistence renal toxicity or renal disease or any other renal pathology, because the ethambutol is finally removed from the body by the kidneys, and if you don't have a good renal function, you are more likely to develop an early toxicity. And also patients who have smokers or some other coexisting ocular comorbidities also could add to this. So it's a good idea, and I think it's the ideal situation is that all patients who are started on before starting ATT, they have a baseline evaluation. Now, that is a little difficult in all setups because ma'am just explained that in primary, that most of the patients who are having, who are on a short duration of uncomplicated tuberculosis will be sent back to their hometown, and the ASHA workers are probably, giving them the medicines and they are monitoring them. So, and ethambutol being a dose-dependent, cumulative, duration-dependent toxicity, most of them are unaware when they develop it. Only when they suddenly lose the vision, they come to you. So there is a, it suddenly, they just alarmed one day that, oh, I cannot see. Most of the time it happens from 3 to 4 months of starting the anti-tuberculosis therapy. In my experience, I've seen it up to 4 months, no problem is, reported by most of the patients. Only after about 3 to 4 months of starting the therapy, some changes happen. And that too is variable from person to person. So I think it's a good idea to have a baseline evaluation. At least the awareness should be there in the primary care physician who's starting that this patient could be a higher, could be at a higher risk of developing ethambutol toxicity. For example, I recently had a patient from a local hospital. He is a young patient, but he's a post-renal transplant patient who was on immunosuppression, who developed tuberculosis. Unfortunately, he was put on ATT without even a baseline screening. He's only 24 years old. And within 3 months, he developed bilateral vision loss. And he had this typical bitemporal hemianopia. And they did MRI and they wanted to give IV methylprednisolone suspecting bilateral optic neuritis. He came to us and we could immediately understand that this is ethambutol induced toxicity, which is which has probably manifested a little early because his renal functions and his kidney was failing. He was awaiting for a second transplant. So that was the situation. Still, the physician did not even think of that possibility. We had to really convince him also that yes, if you get a new kidney, probably it'll, you might recover faster. But we did do an MRI to rule out other things, but I was 100% sure that this was ethambutol toxicity. So the important thing, what I felt is that the awareness is not still the awareness, because most of the physicians feel that it is a reversible toxicity. They will recover. Yes, they do recover. Over a slow recovery is there over a 1.5 years, but it is not complete. In my practice, I am seeing a lot of patients who have residual defects. They do recover to 612, 6.9, but all of them have residual, some kind of visual fields, some sort of GCL thinning, and they do have problems. So,
Yeah.
in my experience, it's a
So,
good idea to do baseline screening, strategize the patients who need earlier screening, and have a close follow up. And I think the awareness is more important. We have to make the physicians aware that this is a very important toxicity, that you need to know about it, and you need to send the patients early enough so that we can detect it early.
okay. So once you have a baseline screening done and you feel that the patient is not having too many risk factors and there are no clinical signs of, EON, then when will you ask for, how frequently would you ask for this follow-up checkups?
I would still ask them to come by at least by 3 months, because this is a pattern I'm seeing. Uncomplicated cases are also getting ethambutol toxicity. Another important thing which I felt this paper did not mention was the body weight of the patients. It is this new, ma'am said, this new National TB Elimination Program. Ever since that has started, we have started seeing a lot of surge in the ethambutol-induced optic neuropathy. I think it's because they have started giving ethambutol in the continuation phase also. It's become a
Yes.
daily dosed regimen rather than an intermittent regimen. And a second thing
And
is,
it's
earlier
also
they
a
used to have,
fixed dose one.
yes, a fixed drug regimen. So you can't stop one drug and then see, like, it comes as a combination. And also it is not intermittent, it's constant. Every day it is there. So, and most in, if you look at the like the dose in this case also, most of them are having more than 15 milligram per kg per body per day in the study also. So in our population where people are likely to have less weight, you should at least think of that fact also. I have a lot of ladies who are less than 50 kg who are put on same weight, same dose. I don't know, despite they have a weight band in that new program, they were put on almost the same dosage. They have developed significant toxicity because of that. So I think the awareness is very important, and I would call them definitely at least by 3 months, even if they don't
Okay.
have any problems.
So every baseline before them, I mean, I'm talking about the ideal. Of course, there are practical difficulties in different setups, but let's talk about the ideal. And the ideal is that there should be a baseline screening, ideally before starting ethambutol, especially since a patient on ethambutol may have many other comorbidities, contributing to his visual loss, as Dr. Sudha was rightly explaining. And secondly, as Dr. Neena was saying, it should be every 3 months. It's good to follow up these patients. So it's a 6-month regimen right now. So that would make baseline every 3 months, 2 more visits during the 6 months. And my final question regarding this follow-up regimen is, when would you stop follow-up? Would you stop follow-up with the drug, or would you continue to follow up till, a few weeks or few months after stoppage of therapy? That's my question.
But see, that's the most important part. So you have to tell the patient that it's a cumulative toxicity. I tell them that the drug is in your body. It has to be eliminated. Now, depending on your renal function test, this drug is going to be slowly eliminated. It has so many oftentimes happen that patient stopped the drug yesterday and patient has covered toxicity, vision loss today. And it continues to worsen even after you stop it, because it's a
Yeah.
cumulative toxicity. So that has to be told to the patient very clearly, that even if you stop the medicine, it will take some time for the drug to be eliminated from your body, and the recovery is going to be just like how the visual dysfunction happened gradually. The recovery is also going to be gradual. So this
I think,
other
Neena, my question was slightly different. This was not about the toxicity and the recovery of vision. I was asking about how long should you be actually having a surveillance for ethambutol toxicity? Does it occur even after stoppage of treatment?
Yes. So, oh no, I'd say, for example, if yes, it can happen. So, ideally, I think they should be on follow-up at least for a year. This is what
Exactly.
I feel, because there are some patients who report toxicity even after stopping the drug, though, most of them would manifest
Uh,
by 3 to 6 months.
okay. So
That
let's
is the
say that
duration.
after 6 months also, when the dose regimen stops after 6 months, even after that, maybe we should have at least two follow-ups every 3 months, 6 months after stoppage of the regimen also. So in short, when you are actually an ideal way to have a surveillance would be baseline before ethambutol, then every 3 months during the dose regimen, and then every 3 months after the dose regimen also. And after 1 year, yes, maybe ideally. So at least 4 or 5 times, one patient may have to come, even though there are no signs of ethambutol toxicity. This is just about surveillance. And as Dr. Nina was saying, once there is ethambutol toxicity, you should counsel the patient that it will take time for the sight, for the vision to recover, even if it does. That is the other point. So I hope the takeaways are clear about the surveillance regimens in suspected ethambutol toxicity, not an established ethambutol toxicity. So now, because of the paucity of time alone, these are all pearls that we are getting, but because of the paucity of time alone, let us move on to those patients where we are actually detecting an RAPD, we are detecting a color vision problem, and clinically, the fundus is also showing some signs of early pallor or maybe a dyschedema. Do we really need to? So we already know that this patient has a ethambutol toxicity. So this question is to Dr. Sudha. Do we actually need to go ahead with all the armamentarium of OCT, vision, whatever, VP, etc., because we already clinically know that this patient has ethambutol? If so, why should we do that?
No. Okay. My this thing answer to that is basically ethambutol toxicity is a clinical diagnosis, or it should be. It should not be based on an investigation diagnosis. I'll give you two reasons for that. Ethambutol toxicity, one is why we suspect it. You should stop the drug once you suspect it. That is what it is. The answer. So why? When do we suspect? When it is a bilateral disease. Okay. When it is bilaterally, the patient is coming to you saying that I am being having vision loss since I started this drug. That is a very clear cut thing. Your fundus may be normal, your color vision may be normal, everything may be normal, but this is a diagnosis where we should have a high index of suspicion that it is because of this drug. And usually, as Nina said, it starts around 3 months, but it can start earlier. It can be unilateral. The problem is you may have other comorbidities which explain. So how there is when you monitor. And it may not be an acute loss, it may be a gradual loss. In fact, the patient may not even have noticed it. There is the problem of why we should monitor. So the other one is clear cut. There you just tell them to stop the drug and it will recover to an extent. But this one, where the patient is not aware, where it may be not, the fundus is not showing any changes, color vision may be normal, what would you use to monitor? Their gradual vision was, yes, I would suggest that we do monitor. But then how do we monitor such patients? Not everybody has an OCT. Ideally, if you are able to, as Nina said, that every 2 to 3 months, if you are doing an RNFL OCT, you will notice the thinning as the drug is cumulative uh, increases, dose increases. If you're able to notice it, you can stop it early. Would that help? I don't know. But if a patient, you don't have OCT, then what is the better way of monitoring such a patient with gradual visual loss and you're suspecting that it could be ethambutol? Maybe if you have a baseline field examination, you should do a field examination now to see if there is any scotoma. Because ethambutol produces a central or a centrocecal scotoma, which is more earlier than your changes in the optic nerve. Structural changes are much later. Your pallor will come later. Even your color vision may not be so early, but field changes and OCT changes are the ones which will be earlier. And if you're monitoring them, and perhaps if you can monitor with a VEP, that would be good. So otherwise, if there is a clear-cut history based on ethambutol, then it's a clinical diagnosis. You don't, it's a retrobulbar neuritis, you cannot see anything on fundus. So it is not, that is not the point. But the history is, and you should have a very high suspicious index there. And I think you have to stop ethambutol then and there.
Okay. So, Nina, do you agree that if patients have a clear-cut clinical diagnosis of ethambutol-induced optic neuropathy, we don't really need to do a field testing or a baseline OCT for that patient? And of course, we should stop the drug. That is not the question. The question is whether we should still complete the investigative armamentarium or not.
So as ma'am said, yeah, it is a clinical diagnosis, but I would get the visual fields and OCT for prognostication. That is also important. I wouldn't do the other battery of optic neuritis workup like MRI and the serology and all those things I would skip. But I would do a complete optic nerve workup, which includes vision, color vision, and your visual fields, as well as an OCT, because OCT, one of the earliest biomarkers of ethambutol toxicity is GCL thinning. In a GCL thinning is now supposedly the earliest biomarker. Much earlier, it happens before even RNFL thins. And if possible, if you have a VP, the P100 latency, prolonged P100 latency, is also one of the earliest indicator. In fact, we have a small study which we might present soon with Dr. Anna Elias. And what we found that it was only P100 latency and GCL thinning which were able to predict the toxicity before the structural changes happened. Visual fields would show some changes, but sometimes they're very non-specific, like peripheral constriction and all that, but before the patient is aware. So once the central scotoma comes and the temporal hemianopia comes, patient is aware of it. They will come to us. So before
Yes.
that, we were able to pick up the early signs of impending ethambutol toxicity with prolonged P100 latency and GCL thinning. So these are two, but these are not available everywhere, as ma'am said. So sometimes you have to have a very high index of suspicion. And if the patient, sometimes they may just say, they may come with frequent change of glasses. One of the complaints they would come is not a defective vision, a frequent change of glasses. So I would do a complete optic neuritis clinical workup, but I would skip the MRI and the serological unwanted lumbar puncture, all those things, if I'm convinced that it is ethambutol toxicity.
Okay. So both all the three of us working in institutes, we have a DC to take these decisions. But if this patient is seen by a solo practitioner, would you suggest that these patients should be referred for these investigations? I mean the OCT. I mean the OCT. Should the patient be actually referred for an OCT? If the clinician is not having the facility.
So, ma'am, you want to answer?
I am not very sure about that actually. In fact, I think our consensus statement in the IGO, which has been given, it says that you get an opportunistic screening. So, whoever is there who is seeing that patient, and as soon as an ophthalmologist, you do whatever screening possibility is available with you. If it's an RAPD, if it's a color vision field, okay. That is one. Second, they have said, and they specifically said that whatever ethambutol toxicity affects central vision. So in poor resource areas, you can actually monitor by just visual acuity. So or by the patient saying, patient will have say that I'm not seeing so clearly as I was before. So even a physician can monitor if he has a daily chart. That is what they recommend. Now you are talking about
Yeah.
ideal situations in institutions where you have OCT.
Yeah,
Would you like
that's
to
a
refer?
question.
That is your individual choice, I think. Yes.
Okay.
If you have the
So
facility nearby, don't harass him for it. But if he is willing to go and get an OCT done. Because OCT is definitely good, as she said, for prognostication as well as to identify the thinning if it is occurring, then you should be careful about it.
So ultimately, the takeaway here, I would say, for all the viewers who are watching us, if you are in a not really in a resource intense situation, if you are in a resource deficit situation, how less you will investigate will depend upon your patient and you, and how you put it across to your patient, and what is the purse capacity of that patient, basically. So I would say what the consensus, the IGO, what was published in the IGO by the Neuro-Ophthalmic Society of India, Dr. Rohit Saxena group, clearly mentions that apart from the clinical investigations, it is the OCT, it is the visual field, that is C24-2 or C30-2 fields, and OCT. are desirable and should be done. And VEP is even less available than OCT, so it was not mentioned. That is why it was not mentioned, not because it's not a good test, but because the accessibility was even less compared to the OCT. So that is the consensus says desirable, and desirable is actually an ambiguous word. So that is why it is difficult for us to decide. And as of now, we have in every patient we have to do a visual acuity, color vision, Paka clinical examination, a visual field. This much most of us will have access to. Whether you do an OCT depends on the patient and you, but ideally an OCT at least should be done if possible. You can, I mean, that's the way you should counsel the patient if possible. Another thing is, Dr. Nina was now saying that science is evolving and it is the ganglion cells combined with the VEP that is now coming up as the most, early indicator for EON. So you should be very clear about what you are wanting for the patient. Is it early detection or is it surveillance? I mean, is it monitoring of already ongoing ethambutol toxicity? So if it is early detection, then OCT, this GCL and the VP will have more of a role for a very early detection. The other one we can even pick up clinically and we can do the measures to arrest it even, and we can bring down the frequency of these hi-fi investigations at every visit, depending upon the risk
One
stratification.
thing about this OCT and VEP and all is that you should have a baseline investigation to follow. I mean, you can only monitor them by serial ones. So unless
Yes,
if the person cannot go for a serial, just one OCT will not help because we
not
don't know
help.
what is a baseline.
But
So
as she said, 3 monthly OCTs for a
yeah,
patient
then only
who
if
has that is where you should risk stratify. Dr. Nina was mentioning the risk factors. If there are risk factors, then your investigative protocol should be more elaborate and more frequent. But otherwise, even 6 monthly is okay. Or even you can monitor and decide when to do. So that sort of flexibility should be there for the clinician also. And regarding the GCL and VP, I think it's I was just going to ask this question, that is, if the patient has a financial crunch of these investigations, they are saying we can do just two of these. We can't do everything. So what will you drop? That is the clinician's dilemma. So personally, if you ask me, I would say my take from all this would be it's just personal. It would be that I would go by clinical examination and maybe I'll skip the fields if I have an OCT, because OCD is the if it is for early detection, because OCD is much more reliable. It has two options, RNFL, GCL. GCL is very coming up as a very reliable thing. So I might as well skip the fields and I might go with the OCT and the GCL for an early detection. So that this is just one example of how I feel about it. Maybe Dr. Sudha has another opinion. Maybe Dr. Nina will think differently. So that's exactly
of
what
you,
this is about.
how many in the periphery would be comfortable even reading an OCT
No, no,
printout?
no, no.
That's a,
I am not. This I'm talking only about when you have a field and OCT and RNFL, but the patient is not able to pay for all the three. Only that
So I think,
situation. That's what.
what I feel is that we must have a chat, heart-to-heart chat with the patient. You must be transparent with
yes,
the
that
patient
is
that
most
yes,
important.
that
Right.
is important. So what I do is that I tell the patient, look, I suspect that you're having this disease, but there is no magical cure for this. Even if I detect that you're having this, what I would do is stop this drug. But I can monitor you better if I have these investigations. So if you're okay with this, we will do this and we will do serial follow-ups. The follow up, I mean, the recovery is going to be slow and gradual. You have to be very patient. If you're okay, we can monitor you, and this will help me to understand whether you're recovering very well. So, when you discuss and leave the ball in their court, most of them would want, because vision is very important. I have seen so many patients totally incapacitated by this and most upset because their physician has never ever told them that this is a possibility with this drug. So, I think that awareness is not is not there in many physicians because they feel yes, life is more important than vision. But what is life without a vision if you are disabled? So that's what most patients ask me, why it was not told to me. I said probably it was not anticipated, but now that you have got it, we can monitor you better with these investigations. Are you okay? Most people will do it, at least in Kerala, which I feel is very different from the rest of the India. Patients are aware of their problems, and they're able to understand better when you tell them the solution and how you're going to go about it.
Okay. Uh, we have time for maximum of 2 questions only. So I'll ask the most important 2 questions. One is, see, whatever we are doing at an individual level is 100 times multiplied if we can actually change policy. So how is it that a general practitioner or a comprehensive ophthalmologist who actually detects an ethambutol induced optic neuropathy, is there any way that he can contribute to changing policy, in the sense that the thing that has now brought this to the forefront is because of the change in the DOTS regimen, and that it became a fixed dose combination where ethambutol was there for 6 months instead of 2 months as earlier, and it became a fixed dose combination, and hence the risk of cumulative toxicity went up. And even with the earlier regimen, it was variably reported between maybe 2 to 12.6% or something, which would have gone up now. But I was having a discussion with one of the policymakers of pulmonology policymakers, and he was telling me that this is not being changed because of the still reported lower incidence of ethambutol-induced optic neuropathy in our part of the world. So how we can contribute is by coming up with the actual statistics, and how it is. We are all saying among ourselves that we are seeing more people. So there should be a proper reporting system. And what should that's where maybe this question is better that it is for Dr. Sudha. So what should be the reporting protocol that a practitioner should follow?
That is very clear. Actually, the government has made it very clear in their listing. The NTP's program involves the surveillance and reporting. So there is a
Yes.
Nikshay app and a Nikshay website where individual doctors can go in. The app is easily downloadable. You can actually report incidences. The other thing is there is, for in a medical college like place, you have a pharmacovigilance committee where you have, if you detect something, you can report to them. That is through the Department of Pharmacology. So these are reportable. And what happened when it started, when, as you said, this started, there was a very high incidence of optic neuropathy in our institution. We actually collected the data and reported it to the pulmonologist, telling them that there is a problem. So they took up the case. Initially, when they started, in fact, they had only 2 or 3 weight bands. They've actually increased it now. So that weight band started because they just had less than so many kilos and less than this kilo, and that was a fixed dose. Once we started reporting it, they realized that there was this problem. They actually made a committee of it, and they pulmonologists had a national evaluation of this. And finally, more weight bands were introduced. So now it is a little less compared to what we started with. So definitely you can make a difference if you report. And it has to be, there are reporting places, it has to be through the district TB program and the Nikshay app.
Okay. Uh, Actually, in our college, our medical college, it is like you said, there's a pharmacovigilance system going on, and the national health mission person is there. We report to them. I mean, there must be some reporting system like that, but even practitioners can just download and straight report also. Can you just once again say the name of the app? Uh,
Nikshay. Nikshay. The
Niksha.
Kshay Rogam is TB. So Nikshay. Nikshay app.
Okay, it's the
NIKS.
Niksha app. Right. So
And
that's
I feel probably we can also raise awareness by, maybe reporting it to IMA or some, multi-speciality groups so that they are also aware of it. Like ma'am is working in a multi-speciality hospital where, medical college setup where she can discuss in the forums. When people are working in isolated eye hospitals, the reach is less. So I think one platform would be to report it to IMA, and probably they can take it up and discuss in a common forum. So these are other ways because policy making happens both ways. So I think
yeah.
because the reporting is very low, that is what is happening. Report because the reporting is very low, people think they think, oh, it's very low, it's as low as 0.01. Why do we want to even consider it?
Actually, Dr. Praveen was asking a very pertinent questions about the statistics of one, what exactly is the incidence of ethambutol induced optic neuropathy in our state right now? I mean, I don't know. I don't know actually. I don't know whether it's reported. Secondly, what is the percentage of people who are actually being sent to us? Percentage of people who are under this dose regimen who are undergoing surveillance. In this study, it was around 13%, right? So we don't know what's the percentage in our state. So such things, and what's the percentage being followed up? I mean, we don't really know what is the percentage of vision drop that is happening in these patients. So it's a lot of research gaps are there in this, and our budding researchers can actually take this up as their. It's a good and it's very nice area where they should come up. We should all actually join hands for this. I think. We are shooting. We have already, shot the past time. So we should be stopping here. Dr. Praveen, anything more to add from your side?
Nope. No.
All right. So then let's call it a day. And usually I make a small summary, maybe 2, 3 sentences. So the customary summary also before I go. So though the consensus or the practice guidelines clearly state certain protocols, the practice of those guidelines should depend upon common sense on the part of the clinician on what your patient can afford, and risk stratification, more importantly, risk stratification as elaborated by Dr. Neena. One glove doesn't fit all. So baseline should be for everyone, but then how frequently you should monitor, what are the protocols you should be monitoring them with, all this you can change. You can actually it's not a mechanized process. You can actually decide depending upon the risk stratification that will help you, and depending upon the patient heart-to-heart talk that she mentioned that you should be having with the patient. And once it is detected, then there is no two thoughts about it. You have to stop the drug and counsel very well that there is no miracle going to happen. It will take some time. Usually it takes a few weeks to few months for the vision to come back. And most importantly, you should never stop surveillance at the time when the dose regimen stops. It should continue ideally for at least 6 months to 1 year after the therapy has stopped. I mean, the patient has been off ATT. So these are some of the thoughts I would like you to. I would like to leave you with. And one of the points that was not discussed here was regarding the influence of diabetes on ATT. So there are some thoughts saying that glitazones and some drugs that are used by the diabetics can have influences on ethambutol toxicity too. But then that maybe we can take it up another day. So it was very nice having this sort of conversations, and I learned a lot from both of your experiences and the immense insights that Dr. Praveen offered through the article. So it was a great learning experience for me as well. Thank you all for being with us today.
Thank you, Latika, for the opportunity. And thank you, ma'am, for your insights. Thank you,
And
Dr.
for the,
Praveen, for the wonderful analysis of the paper.
yeah.
Yes,
So the
Dr.
viewers,
Pravi made
before
it
I
so
forget,
easy. It was such a
he
difficult.
only said what we can understand. That's the beauty of Dr. Praveen's
Because we were
discussion.
confused, as I was discussing with you before, we were confused about that age and sex which that paper was discussing. So it was really interesting to see Dr. Praveen take it up in a proper way. Thank you all for a very wonderful, fruitful discussion.
And before I go, just let me remind our viewers that a quiz will be right now. It will be live just after this. So come and take that quiz. It's not just competitive, it's a self-directed learning exercise also. It will be live on the website. And in all the groups, I'll be just now sharing the link to the quiz also. So thank you so much. Till we meet, good night.